The atherosclerosis, it's a very common, so it's a very common disease. It's a disease of elastic and large and medium-sized muscular arteries. So basically, this is what these are the categories that we have. It's elastic arteries and large with medium-sized muscular arteries. It's a form of atherosclerosis caused by buildup of cholesterol plaques in tunica intima. So basically, there is a buildup of plaques of cholesterol in the inner layer or the visceral face of the vessel. So if you could take a look at this image again, there you go. This is the tunica intima. So it's the very inner layer of a vessel. Well, and the location, it could happen at multiple places, but most commonly it occurs in the abdominal aorta. So it's the aorta that is going into the abdomen. Then it's more common than the coronary artery, which is more common than the popliteal artery, which is more common than the carotid artery, then more common than the circumflex. So in order to memorize it, there is a copy cat named Willis. So basically, it's if you want to memorize it, then there is abdomen, regulated place, and then a coronary artery, then heart, then popliteal, that is behind the knee, and then there is carotid, that is in the neck, and then the head. Okay, so not really. For the risk factors, they could be modifiable. The risk factors could be something that we can do, something about to avoid, or non-modifiable that we cannot change, we cannot play with at all. So for the modifiable, there is hypertension, we could control it, or tobacco smoking, we could stop it. There is dyslipidemia, we can regulate it. For example, in dyslipidemia, there is increased low density lipoprotein, and also there is decreased high density lipoproteins. And in diabetes, we also can control it. So these are the modifiable risk factors. The non-modifiables are just like age, if they're old age or something, male sex, if it's postmenopausal status, and also family history. So these are things that we cannot actually change. For the symptoms of atherosclerosis, we could have angina, that is chest pain, most likely associated with exertion. Also claudication, that is not the ability, losing the ability to walk properly. So that what does it mean generally? So claudication or angina, but can be at the same time, can be asymptomatic. So it doesn't have to be always with too many symptoms. It could be just asymptomatic. For the progression of atherosclerosis, it's basically, even though, as the name says, is just a plaque of buildup, as we said here, cholesterol plaques in the tunica intima, but actually it starts with inflammation. So the inflammation is important in the pathogenesis if there is an endothelial cell dysfunction, and we can tell because it happens in the abdominal aorta most likely. So it's due to the turbulent flow. So this turbulent, so if this, let's say this is the aorta or the artery, and this is the lumen, and there's blood over here, so it's just attaching, or not attaching, actually hitting the walls, hitting the endothelium. So if it keeps hitting, because it's not like a nice calm flow, if it's turbulent flow, if it's too much of a blood, then it will hurt the endothelium over here and cause like an endothelial injury. So it's called endothelial cell dysfunction. That dysfunction definitely would lead to macrophage and low density lipoprotein accumulation. So we know that whenever there is a problem in the body, the macrophages are just welcomed to that place. So macrophages and LDL accumulate in the place of endothelial cell dysfunction. So that leads to the foam cell formation. So if you go here with the diagram here, so this is the endothelium, as we said, it's the inner layer. This is the smooth muscle that is in the middle layer. So our problem is with the inner layer. So if we have damaged endothelium, then the first thing to come over here is the macrophages. And the macrophages will accumulate with the low density lipoprotein laden macrophages, so it will somehow eat that low density lipoprotein. So and will also with fatty streaks, that is the low density lipoproteins. So all of that would cause these yellow pieces over here. These are called foam cells. So these foam cells, if they accumulate, they would cause the whole process to be to produce fatty streaks. So the fatty streaks would lead to also smooth muscle migration, which involves the platelet-derived growth factor and fibroblastic growth factor. So the smooth muscle migration comes probably due to the call of two main cytokines over here, or just factors, let's say, the platelet-derived growth factor and the fibroblastic growth factor. So, of course, after the smooth muscle migrates, which means comes to that place, it proliferates, okay, and starts producing extracellular matrix deposition. So it just doesn't just go and sit there. It just migrates and then proliferates and then just produces the extracellular matrix deposition. That, of course, is going to develop into fibrous plaque. Now, it's because we had the fibroblastic growth factor working, the platelet-derived growth factor working, and we have the smooth muscle cells coming. So now it's a fibrous plaque that is forming. So there you go. This is the fibrous plaque in the diagram. This pink, actually these pink pieces are just the smooth muscle, as we said. So they're just migrating to that place. After all of that is happening, we have complex atheroma. So this is a complex atheroma. This is the vessel lumen, and this is the whole wall, and this part is the complex atheroma. And as you can tell just by looking, it doesn't look like the normal wall. This is normal, while this is the complex atheroma. So the complex atheroma leads to calcification. So calcification is basically, as what it says, it's calcium content correlates with the risk of complications. So the calcification, if we have an amount of calcium content, it does have a relationship with the complication that this complex atheroma may lead to. So the amount of calcium content that we have in the complex atheroma, that is going to impact how much complications we can have, or what's going to get any worse. So for the complications, we have aneurysms, we have ischemia, we have infarcts, peripheral vascular disease, thrombus, and emboli. Aneurysms, ischemia, infarcts, peripheral vascular disease, thrombus, and emboli. So all of it like vascular problems. So that's all for atherosclerosis, actually. Not too much. For now, for the aortic aneurysm, it's when I read aneurysm, I think kind of a cyst, and there you go. It's actually here, so it kind of look like a cyst. Yeah. So for the aortic aneurysm, it's localized basically. So it's not migrating or something. It's just localized, pathologic, of course, dilatation of the aorta. So of the aorta, as we said, because it's aortic aneurysm, may cause abdominal and or back pain. So it's either just abdominal or just back pain or both, which is a sign of leaking. If we have that pain, that is important, because this could be a sign of leaking or dissection occurring in the wall, or imminent rupture. That is something to expect, that really the rupture is going to happen soon. So if we have pain, then we need to be like really careful that the rupture won't happen immediately. For the aortic aneurysm, we have two main sites for the aneurysm to happen. One in this is this thoracic aortic aneurysm, and the other one is the abdominal aortic aneurysm. So for the thoracic, it's in the chest, actually in the aorta of the chest. So basically, it's associated with cystic medial degeneration. The risk factors include hypertension, bicuspid aortic valve, connective tissue disease like Marfan syndrome. Okay, so not much to add over here, but it's associated with cystic medial degeneration. It's also associated with tertiary syphilis. Okay, because the tertiary syphilis has obliterative endarteritis of the vasa vasorum. Basically, the vasa vasorum are the very teeny tiny small vessels that actually supply the vessel wall itself. So for example, this is the vessel wall. So it's basically, there is blood going in here. Actually, this is a vessel, okay? But this vessel still needs supply from the outside, coming from the heart. So this is what is called the vasa vasorum. So in tertiary syphilis, there is some kind of obliterative endarteritis. So it causes an inflammation in these end arteries. So that's why it's called obliterative endarteritis. So basically, it's causing these vasa vasorum vessels to be obliterated. If they are doing so, that means they are not sufficiently providing the main vessel wall. So they're not actually supplying the adventitia of that wall that we're talking about, the vessel wall, which means the adventitia, or the outside layer of the vessel that we have here. So this is the adventitia. It's the outsider layer. And the vasa vasorum are over here supplying this vessel, the whole thing. So if they're not doing that anymore because of the tertiary syphilis, which has the obliterative endarteritis, that means the adventitia gets weak, as in here. So it gets weak, and now there is more possibility to develop an aneurysm, okay? Because the vessel wall is not as strong as it was. That's the case in thoracic aortic aneurysm. So it says aortic root dilatation may lead to aortic valve regurgitation, okay? If we have the problem or the aneurysm in the aortic root, that may lead to aortic valve regurgitation. It makes sense due to close proximity of the two structures. Now for the abdominal aortic aneurysm, it is associated with a transmural, like the whole wall of the vessel. So basically it's all three layers of the vessel. So transmural inflammation and extracellular matrix degradation. So basically we have two processes here. First one is having an inflammation, and the other one is just degradation of the extracellular matrix. The risk factors include tobacco use, older age, male sex, family history, may present as palpable pulsatile abdominal mass. So if it's abdominal aorta, then most likely it would come, or not most likely, but it actually may present as palpable pulsatile abdominal mass. So we can physically palpate the abdomen and feel that there is a mass that is going up and down with the pulses. So it's the arrow in A points to an outer dilatation of the aortic wall. So let's see here. Let's imagine that this white thing over here is the lumen of the vessel, and this should be the wall, like it should be ending till here. So this is the vessel wall. But what is happening is that we do have this dilatation. This blue thing that I'm coloring is the abnormal dilatation. It should be only like this. This is a nice vessel wall, but it's actually dilating. So this is what is considered an abdominal aortic aneurysm. So the rupture may present as a triad. So there are three main symptoms. A pulsatile abdominal mass, that's what we talked about. We can find it by physical examination, and also acute. So it's not something that developing over time. It's very sudden and acute abdominal and or back pain. Okay, so it's acute abdominal and or back pain with resistant hypotension. If you think about it, then if it ruptures, it's an aorta, like abdominal aortic aneurysm. If it ruptures, that means a lot of the blood in the aorta is going into the wrong place, and it's the major artery of the body. So if it ruptures, then will definitely lead to resistant hypotension. No matter what you do, it's just going to say hypotension because the aorta is broken, and that's definitely not good. So most often infrarenal disturbance of vasovasorum is reduced. So basically it happens most likely or most often in the infrarenal arteries, like the arteries that are below the renal arteries. So because the distribution of the vasovasorum is reduced in these places, in the infrarenal, so that means there's not much vessels supplying or feeding the infrarenal arteries. So the infrarenal arteries are not as strong as any other place, okay? So what we have here is the color-coded image, the ascending thoracic aorta. So basically this purple thing, this is, as we know, the, okay, ascending thoracic aorta, and then the aortic arch is the blue thing. Okay, this is the aortic arch, and then the descending thoracic aorta, this is it, and then the green thing is the abdominal aorta. So all of these places are somehow unexpected places to develop an aortic aneurysm, as it seems. It could be like this, a fusiform aneurysm, if it's, let's say, well, on two sides, and the saccular aneurysm could be like this because it's only on one side. So that's a saccular. So basically it looks like a sac. It looks like a bag coming out, okay?